Great. Thank you all very much for those for that great discussion, as Dr. Chen mentioned. So for the remainder of the panel session, each of our speakers are going to sort of wrap up some of the thoughts from the discussion and from the thyroid operative standards to talk and give some take-home points on the content of the text. So I think we're going to start with Dr. Yip.
So some take-home points from the preoperative evaluation. So there are certainly many variables that can affect the extent of surgery. So older age, by the current AJCC 8th edition staging, this does potentially increase the staging for patients. And so sometimes that is a variable that's important to take into account. A family history, especially of multiple first-degree relatives with thyroid cancer, is concerning. And certainly if they have a history of head or neck radiation, especially as a pediatric patient, then that could potentially increase the risk of multifocal disease, which may guide the need for potentially an upfront total thyroidectomy if you're concerned about thyroid cancer during the initial evaluation. Certainly we talked about using ultrasound and other types of imaging to assess the extent of disease. Any prior head and neck surgery can potentially alter the thought process behind how much surgery. If you're worried about scarring in one side, that may potentially lead you towards a lobectomy instead of a total. But on the other hand, if you have issues as well as if you have issues related to the recurrent laryngeal nerve, that can also potentially change your extent of surgery. Certainly there's a role for patient preference. Every conversation that I have regarding thyroid surgery, I discuss with the patient what the pluses and minuses to each type of surgery are. There's certainly a role for the surgeon to guide the patient, but sometimes if it's equivocal, then their preferences are important. And I think one thing that we really emphasize in the operative standards is really how the extent of surgery is also very heavily contingent on multidisciplinary input and practice patterns of your collaborators. And so certainly endocrinologists and oncology people who are going to be helping to follow and to come up with a plan of care for patients with thyroid cancer, sort of what those plans are will also greatly influence what kind of surgery we offer up front. A number of key findings on physical exam are voice quality and changes, as Dr. Severio talked about. This can really affect whether or not you get a vocal cord assessment preoperatively. This can include either a direct or indirect laryngoscopy, and there's certainly many people who also do laryngeal ultrasound as their exam of choice. A significant dysphagia or dynaphasia, hemoptysis can suggest potential involvement of the adjacent structures and may guide the need for bronchoscopy or even EGD at the time of surgery. Nodule mobility and the presence of lateral lymph nodes can also be very important to assess on exam. These sorts of things can impact, sort of how you're concerned about cancer and whether or not this is going to be something that's going to be resectable versus unresectable, and guide the need for further imaging as well. Next slide, please. We talked about ultrasound being the gold standard imaging. This provides information about the tumor size, location, presence or absence of extracellular extension, contralateral lesions, which are also important to assess, and the presence of nodal metastases. And then we've already talked a little bit about CT imaging or MRI when needed. Either is fine. It's really institutional preference in terms of which works better for you. This is usually indicated with bulky lateral or central lymphadenopathy to assess mediastinal involvement, which is easier to resect at the initial operation if reachable. Invasion of adjacent structures, including the great vessels, as well as the esophagus and trachea. And IV contrast is often necessary, as we again talked about. There's no reason to shy away from IV contrast. If the patient needs radioactive iodine postoperatively, then we can certainly measure urine iodine excretion to be able to make sure that it's given to them at the appropriate time.
Great. Thank you, Dr. Yip.